So today we will be seeing the NEET PG 2025 Medicine Recall. I'm Dr. Karthikeyan, Medicine faculty. So let's start with the first question, which is the 70-year-old hypertensive patient in atrial fibrillation. Patient had complaints of weakness of upper and lower limb on one side since last 2 hours. And his sensitivity head was done, which was found to be normal. What is the next step in management? A. Check for atrial thrombi by transesophageal echocardiography. B. Do a thrombolysis. C. Mechanical thrombectomy. D. Rate control needed. So for this, you should actually know the concept of management of stroke. In stroke, within 20 minutes of patient arrival, you must be getting a NCCT head done. It is just to rule out hemorrhage, not to diagnose stroke, ischemic stroke. Okay. So here in NCCT head, if you are able to see like white areas with surrounding black edematous areas, then it suggests intracerebral hemorrhage. If it is just edema or if it is given to be normal, then it rules out intracerebral hemorrhage. Then it means that it is an ischemic stroke. So management of stroke, first thing you should be knowing airway, breathing and circulation to be established. That should be managed first. Then comes the BP and dextrose control in stroke. Then comes the NCCT head. So what is the BP and dextrose control to be taken into account? We will be learning it. And in ischemic stroke, most important thing is time since symptom onset. Okay. So here, if you see RBS sugar control, if it is less than 60, you should treat. If it is more than 180, you must treat. Target level 140 to 180 should be your target level. And with respect to BP control, which is most important in stroke, ischemic stroke, if the patient is eligible for thrombolysis, BP should be controlled to less than 185, 110 should be the goal. If the patient is thrombolysis eligible. If the patient is not thrombolysis eligible, then BP should be controlled to less than 220, 120. Okay. So next thing, what you should do in ischemic stroke is time since stroke onset. So if it is less than 4.5 hours, which is the golden window period, like as it was given as 2 hours in our question, then first thing what you should see is whether the patient is thrombolysis eligible or not, irrespective of whatever the cause of the stroke is there. If the patient is thrombolysis eligible, then you should go for IV thrombolysis. Thrombolytic agent used in ischemic stroke is alteplase. Okay. Or if the patient is not thrombolysis eligible, if there is any contraindications, then you can get a CT angiography to look for the thrombus, and if there is a thrombus, you can go remove the thrombus mechanically, which is mechanical thrombectomy. And if the patient presents to you in 4.5 to 25 hours, then only option is mechanical thrombectomy. If he is eligible, you can go for mechanical thrombectomy, or if he is not eligible, only option, or if the patient is presenting to you more than 24 hours, only option is just to give antiplatelet and statins. Okay, so coming on to anti-alteplase, indications are, as you know, more than 18 years, times in stroke onset, golden period 4.5 hours for ischemic stroke, and goal of BP is less than 180 to 110 with clinical signs of ischemic stroke. These indications are fitting in your question also. So, and there are no contraindications described in your questions also, like any subarachnoid hemorrhage or any pre-hemorrhagic stroke, okay, any head injury or ischemic stroke in last 3 months, or active GI bleed. And in cardiac, contraindications are only 2. One is, as we have discussed, active infective endocarditis or aortic dissection. In aortic dissection, if you give thrombolytic agent, this dissecting flap will progress and the patient will die due to aortic dissection. Okay, so these are the contraindications. So coming on to our question, if you see, there are no contraindications existing for thrombolysis. And NCCT is normal within 2 hours of presentation. It's a classical ischemic stroke within window period. The first option should be to go for thrombolysis. Okay, yes, the option. So answer is option B, thrombolysis. Next is a diabetic patient on insulin and tab metformin, still HbA1c is 8.3 and with signs of heart failure also. Next appropriate add-on medications. So here if you see, as per ADA guidelines, if you see, first is to add metformin, and then if the patient is a known case of ASCVD, atherosclerotic cardiovascular disease, or heart failure, or CKD, the next add-on medications in everything will be a GLP-1 agonist or a SGLT2 inhibitor. Okay, if the heart failure is there, no doubt at all, your option should be an SGLT2 inhibitor, because it has become in heart failure guidelines. If you see, this is the heart failure guideline, ADA guidelines. If you see, in all stages of heart failure, stage A, B, C, everywhere, if you see, this SGLT2 has come into picture, having class 1 indications also. So that means the without no doubt, you can go for SGLT2 inhibitor. The given drug was empagliflozin. So that is the appropriate answer. Coming on to the third question, a 60-year-old male with history of ischemic cardiomyopathy with ECG showing narrow QRS tachycardias and he is hemodynamically stable. Decision is made to initiate antiarrhythmic therapy and IV amiodarone was started. And the basic question was, and what mechanism of action was amiodarone acting? See, nothing but the cardiac action potential. If you are familiar with what we have discussed, if you have known that concept, it's very easy to crack this question. See, first is this phase 0, where the sodium influx happens, which is corresponding to rapid depolarization, and this produces the QRS complex in the ECG. Followed by phase 1, which is the efflux of potassium, start of repolarization, and phase 2, where potassium effluxes out and calcium influxes in, so the balance is produced, and this produces the ST, isoelectric segment, ST. And after which, if you see, there is the phase 3, where only there is potassium efflux, phase 3 of repolarization. So yeah, our amiodarone acts on multiple channels, but majority of amiodarone acts on this channel, which is the potassium channel blocker, which blocks the phase 3 of action potential. So it prolongs the phase 3 of action potential. So action potential duration is prolonged. So what will happen here? So your T wave, the repolarization T wave will also be prolonged. So in amiodarone patients, if you see, the QT interval will be prolonged, but it does not have to do with anything with sodium channel blockage. So QRS is maintained normal, but QT interval is prolonged, which means prolonged QTs, patients has a proarrhythmic risk with amiodarone also. This should be known. So the action is, it acts on the phase 3 of repolarization. Yes. Next question, PDA develops from which of the following arches? See, for this, the aortic arches, as we discussed, it's very important. See, this is the 6th aortic arch. In 6th aortic arch, if you see closely, the 6th aortic arch gives the left and right pulmonary artery. The proximal portions of the left and right 6th aortic arch gives the pulmonary artery. The distal portions of the left 6th aortic arch gives rise to this structure, which is the ductus arteriosus. Okay, so it develops from the left 6th aortic arch. This is the right answer. Next is drug used for the prophylaxis of PSVT, they have asked. So actually PSVT management we have discussed thoroughly. The first is always to go for vagal maneuvers which stimulate the vagus nerves and it causes cessation of PSVT. So vagal maneuvers like carotid sinus massage you can try if the patient doesn't have any history of CVA, TAA or carotid bruit or carotid stenosis. Or you can also stimulate the vagus nerve by asking the patient to cough, by asking the patient to gag, or splashing ice cold water on the face. Okay, and then comes the ABG management of PSVT. Like IV adenosine can be given by fast IV push, which 6 mg, 12 mg, 12 mg, followed by any beta blocker or calcium channel blocker can be given. So this is the management of PSVT. But they have asked for prophylaxis. So for prophylaxis, it is always oral beta blocker or oral calcium channel blocker. Among the option, oral verapamil was given. So that is the perfect option for our question. Next, three ABG questions were asked. All out of all we have discussed it previously. A 45-year-old man has electrolytes of sodium 130, chloride 84, bicarb 16. What is the anion gap they have asked? Okay, it's nothing simple. Anion gap, we have discussed also. See this is nothing but the usually in our body, the number of anions is equal to number of cations. But what happens is the unmeasurable anions, if you take, unmeasurable cations, if you take, these are potassium, magnesium, calcium. And unmeasurable anions are also there in our body, like sulfate, phosphate, and proteins. There are a lot of unmeasurable anions. So there always exists a gap called anion gap. How to measure this gap? See, subtract the measurable cations. What is the measurable cation? Which is the sodium. Subtract sodium from chloride and bicarb, which are the measurable anions. If you subtract chloride and bicarb from sodium, you will get that gap, which is the anion gap. Okay, so if you apply this in our formula, sodium, which is 130 minus chloride plus bicarb, if you do, the answer you can get it around is actually 30. Answer was 30. Next question, simple question they have asked in ABG, nothing but a 60-year-old man with history of COPD they have given and pH of 7.3, PCO2 60. Bicarb they have given some value. What is the primary acid-base disorder? First step of our acid-base disturbance they have asked. See, the normal values you should be remembering. Normal pH 7.35 to 7.45, single value 7.4, and normal PCO2 35 to 40, single value 40. Normal bicarb 22 to 26, single value 24. So first step is to look for pH. Here we have seen the pH is less than 7.35, it is fitting into acidosis. Next, you are going to see PCO2, it is 60, which is more than 40, so it is fitting into respiratory acidosis. Only these two steps calculation they have asked in the question. So it's very easy, it's respiratory acidosis. Next question what they have asked was, a 28-year-old man goes trekking in Himalayas and ascends rapidly to high altitude. He develops headache but mild shortness of breath, otherwise stable. What acid-base disturbance is likely to encounter? See, in acclimatization, what happens actually? The patient has increased respiratory rate due to chronic hypoxia in high altitude region. So increased respiratory rate will what will it cause? It will cause PCO2 to wash out from your body. Due to increased respiratory rate, all the PCO2 will be washed out. So that will lead to low PCO2 condition, low carbonic acid. So that is nothing but it is a condition of respiratory alkalosis. Right option is respiratory alkalosis. And cause of HAGMA also we have discussed here, like high anion gap, the question was. So you should know that cause of HAGMA fit into 5 causes. One can be any toxins or drugs, drug abuse, or it can be a CKD, congestive cardiac failure, or DKA. These 5 causes will be causes of HAGMA, like toxins like carbon monoxide poisoning, cyanide poisoning, aminoglycoside poisoning, okay, toluene, methanol, cat mud piles, the mnemonic, U for uremia, K for ketoacidosis, and piles for peoples like iron, isoniazid toxicity, lactic acidosis, okay, ethanol, ethylene glycol, salicylates, all these are causes of HAGMA. Cat mud piles, okay, yes. Next, one question they have asked, perifollicular hemorrhage and patient is having some bleeding history, symptoms normalized after giving IV vitamin K injection. The answer is nothing but biliary duct obstruction, because the fat soluble vitamins are not able to be absorbed. They are absorbed only by your bile. Okay, if that bile duct is obstructed, your fat soluble vitamins won't be acting properly to absorb the to act properly. Okay, there will be vitamin K, vitamin A, E, D, all deficiency. So here vitamin K deficiency they have given, and it normalized after giving IV vitamin K. This is nothing but biliary obstruction. Next, a patient with the right-sided weakness of one side, which is of element type, and absent reflexes on that side, with no sensory deficit. Site of localization they have asked. See this closely. We have discussed this also. Human lesion versus element lesion. So if you see element lesion, it is nothing but patient will be having flaccidity, and weakness will be, power will be lost more than human, and reflexes will be lost completely, deep non-reflexes, and patient might have fasciculations as well as fibrillations. So here they have given a proper case of element lesion. So if it is an element lesion, it can be from the anterior gray horn, root, nerve, or NMJ or muscle. So now our question focuses telling that there is no sensory deficit. If it is a nerve involvement, then there will be sensory as well as motor involvement. So it is nerve is also rare here. So only option fitting is anterior gray horn. Okay, so option might be like anterior horn cell will be the right option. Carpopedal spasm complication of which surgery? Nothing but thyroid surgery. See what happens in thyroid surgeries after removal of thyroid, parathyroid glands are also removed. So if PTH deficiency will cause hypocalcemia. Okay, actually this calcium, what it does is it forms plugs in the sodium voltage gated sodium channels present in the neurons. Okay, so if there is hypocalcemia, there is no plugs now. Sodium can easily trickle into the neurons and they can cause unnecessarily depolarization. So this depolarization will be transmitted as the muscles will be contracted, continuous muscle contraction, which is nothing but tetany. This can happen. And also muscle spasms can happen multiple areas. Like this is the basics for laryngospasm, bronchospasm, tetany, Trousers sign. Okay. And also due to unnecessary stimulation of the skin tissues also, patient will be having paresthesias, numbness, circummoral numbness. These are characteristic of hypocalcemia. Okay, so these happens only because of this mechanism. This also you should be knowing. It's a complication of thyroid surgery due to absence of PTH hormone. Next, hyponatremia patient develops signs of stroke. Next investigation to do is, see they are given like symptoms suggestive of osmotic demyelination. They are given symptoms. So what should be the next investigation? See, once osmotic demyelination develops in hyponatremia, it can closely resemble a brainstem stroke. Okay, so to differentiate it from stroke as well as ODS diagnosis heavily depends only on one investigation, which is nothing but MRI, because both have close resemblance, like spastic quadriparesis will be seen in ODS and pseudobulbar palsy will be seen because the upper motor neuron supplying the bulbar nerves like 9, 10, 11, 12 nerves, they are affected here. On locked-in syndrome, quadriparesis, patient is not able to move at all with altered consciousness. Okay, and oculomotor dysfunction due to involvement of nerves involvement, oculomotor functions also like 3, 4, 6, and Parkinsonism features also. So everything will be mimicking brainstem stroke. So best thing to differentiate is to get a MRI brain done. Okay. Next, which of the following conditions is most likely to follow this pattern of inheritance? See, in this pattern of inheritance, if you see, watch it closely. When the mother is affected, all children born to that mother are getting affected. Okay. Here, if the father is affected, no one is affected from the generation. But again, when the mother is affected, all children are getting affected in that generation. That means the disease is getting transmitted through the maternal ova. Okay, nothing but mitochondrial inheritance. Okay, the disease which is having mitochondrial inheritance is Kearns-Sarre syndrome. Okay, yes. Next, coming on to 12th question, a patient presents with salt craving, hyperkalemia, metabolic acidosis, skin pigmentation. What is the most likely diagnosis? This also we have discussed in endocrine. It's nothing but 2 pages of endocrine we discussed. In that, they have asked 2 questions. Okay, in that adrenal chapter. See, adrenal insufficiency. It can be primary or secondary. Primary means the gland is affected, adrenal gland itself is affected. Secondary means pituitary stimulation to adrenal is affected. So only this is happening. Okay. So here what will be happening? Adrenal gland is affected. Most common what you can see is Addison's disease, chronic adrenocortical insufficiency. Okay, Addison's disease. So here what will happen to ACTH? Since adrenocortical insufficiency is there, the reciprocal stimulation will cause increase in ACTH from the pituitary. Here, since pituitary itself is damaged, so what will happen? There will be low ACTH resulting in low cortisol and low aldosterone levels from the adrenals. Whereas here, it is the disorder of the adrenal gland. So adrenal gland is not secreting cortisol and aldosterone. So that will lead to reciprocal elevation in the ACTH. Okay, this is the main hormonal differences. Next, if you see the clinical features, what happens? Cortisol and aldosterone is not there. So what is the mechanism of cortisol and aldosterone? Aldosterone mechanism action we discussed also. What it does is sodium water retention and potassium and proton excretion. Okay, this is the normal mechanism of action of aldosterone. Okay, so if this aldosterone is deficient, what will happen to sodium? Sodium water retention won't happen. Sodium levels will start falling. Sodium water retention is not happening, so lot of fluid is lost in urine, leading to hypotension. And potassium excretion is not happening due to aldosterone loss. So potassium will start accumulating. There will be hyperkalemia, hyponatremia, hypotension due to low aldosterone levels. Okay, then due to low cortisol levels, if you see, glucose levels will be going low. Hypoglycemia, and cortisol is one thing which is responsible for BP also. This thing also. So that will also contribute to hypotension, and patient will have weight loss due to low cortisol and hyponatremia. So all these features will be seen due to decreased cortisol. Okay, and due to decreased androgens, there will be loss of libido and hair loss will be seen. Okay, the secondary sexual characters will be absent. So all these are characteristic of features of adrenal insufficiency. Okay, so this is what we got in exam: hyperkalemia, metabolic acidosis, salt craving. Since sodium is lost in urine, there will be salt craving for the patient to increase his BP also. Okay, and skin pigmentation they are given. What is the meaning of that? Why is the skin pigmented happening? See, due to reciprocal elevation of ACTH, this stimulates the melanocytes and melanin pigmentation happens. And there will be hyperpigmentation even in the mucosal regions like buccal mucosal hyperpigmentation. Lot of hyperpigmentation will be. Okay, if there is low ACTH due to secondary adrenal insufficiency, then there will be decreased melanin, and this is called alabaster syndrome. All these we have discussed. Okay, so this is the mechanism. So now you should always check for the diagnostic test for this. What is the diagnostic test? Which is nothing but co-syntropin, which is nothing but artificial ACTH, synthetic ACTH we are going to give for the patient. Okay, so what will happen in primary adrenal insufficiency? There is low cortisol as well as aldosterone and high ACTH, already high ACTH. So now you are injecting this patient with ACTH. So what will happen? The cortisol levels you will be seeing what is going to happen at 30 minutes as well as 60 minutes. Okay, if there is primary adrenal insufficiency where there is already ACTH is high. So now if you give more ACTH, you won't be having a more increase in the level of cortisol and aldosterone. Okay, so this is the test of choice for primary adrenal insufficiency. And treatment is just replace glucocorticoids and mineralocorticoids, like give cortisol as well as like steroid replacements and aldosterone replacements in the form of fludrocortisone. Okay, this you should be knowing. And if it is like a secondary adrenal insufficiency, if you give ACTH is also deficient hormone there. So if you give ACTH, cortisol will be spiked up. Okay, that will diagnose, differentiate primary versus secondary. Okay, yes. So see, next question also they have asked same thing: hyperpigmentation in Addison's disease due to increased secretion of ACTH, which will stimulate the melanocytes. This also we have discussed. Yeah. Next is decay. Same thing. Type 1 diabetic presenting with signs of dehydration, RBS of 799, hyponatremia and chloride 88. What is not used in the initial management? See, DKA management we will discuss multiple number of times. So here if you see nothing but first DKA, first thing what you should do is you should check for the precipitating events. Like 3 I's you should check for infection, infarction or inadequate insulin. If anything is fitting is there or not. Then how are you going to manage? Diabetic ketoacidosis. RBS of 250 to 600. Ketones, blood ketones positive. Acidosis, meaning pH less than 7.35. So treatment is first give fluid. IV fluid, 2 to 3 liters of fluid in the first hour is the essential treatment in DKA. Next, you can start insulin infusion, regular insulin infusion, just to suppress the production of ketone bodies. Next, you should be giving potassium supplementation. This is the order of treatment. In an IV fluid of choice is 0.9% NaCl, saline. Okay, so here 0.9% saline, insulin, potassium monitoring should be done. 3% saline is not at all preferred in DKA. Already the patient is having increased osmolarity. If you give 3% NS, it will just increase osmolarity and it will further worsen DKA. Okay, so potassium we have learned like less than 3.3 only you should give potassium replacement. And then you should start consider only once the potassium improves you can go for insulin. But if the potassium is 3.3 to 5.5, you can give insulin infusion also plus IV potassium also, because DKA is always a situation of potassium loss. Okay, so even if it is a normal potassium, you must give potassium supplement. If it is more than 5.5, you should give only insulin infusion. Since there is hyperkalemia, no need to give potassium. If it is only 3.3, you should give only potassium, increase the potassium, then go for insulin. Okay, because insulin causes hypokalemia. This is the chart we have discussed. Okay. Next is patient in hospital was given IV fluid and patient developed hyperchloremic metabolic acidosis. Which fluid would have caused this? See, if you give 0.9% NaCl, what will happen? First is this 0.9% NaCl, which increase the chloride accumulation in the body. It will cause hyperchloremia. Okay, and also this causes metabolic acidosis also. So the fluid which can cause metabolic acidosis as well as hyperchloremia is nothing but your 0.9% NaC. Okay, RL would have caused, like RL wouldn't have caused acidosis. It will just increase the lactate levels and it will cause alkalosis. Okay, yes. Next thing is, and this thing you should be also knowing, like this 0.9% NaCl if you give, it will suppress the renin-aldosterone axis also. So due to low aldosterone levels, also there is metabolic acidosis. Okay, yes. A middle-aged man presenting with chronic lower back pain and morning stiffness that improves with activity. This is the classical finding of what? Low back pain with early morning stiffness, and middle-aged man classical of ankylosing spondylitis. So here the diagnostic choice is MRI of sacroiliac joints. Next, patient came with fever, headache, nuchal rigidity, and lumbar puncture shows gram-negative diplococci in gram stains. Which of the following will be used for chemoprophylaxis in close contacts of the patient with meningococcal meningitis? Nothing but you must always prefer rifampicin. Treatment you will be preferring ceftriaxone, but prophylaxis drug of choice is rifampicin for the close contacts. Okay. So this we have discussed also, like CSF, like they see this kind of CSF, cobweb appearance due to increased protein exudation seen in tubercular meningitis. Okay, and this CSF, soap bubble appearance seen in cryptococci, and see gram positive in pairs, which can be seen in our strep pneumonia, and also this is the gram negative and intracellular within the neutrophils, polymorphonuclear neutrophils. Is nothing but meningococci, and drug of choice for treatment is ceftriaxone, whereas drug of choice for chemoprophylaxis is rifampicin. Next, a patient presenting with morning stiffness and test positive for anti-CCP antibodies. Which of the following histological features is most characteristic of the underlying disease? So nothing but, see, they are telling morning stiffness, Positive for anti-CCP antibodies, nothing but they are trying to tell you that patient is having rheumatoid arthritis. So here, most characteristic finding is nothing but pannus formation, and it is an erosive arthropathy. So it is nothing but pannus formation with erosive joint damage. So what is the criteria used for rheumatoid arthritis? Euler's criteria. I can tell a simple way how to remember rheumatoid arthritis Euler's criteria. It is nothing but just remember the name, rheumatoid arthritis. Okay, rheumatoid. So what rheumatoid? Serology check for rheumatoid. Rheumatoid factor or anti-CCP. The score is if both negative 0, if both positive 3. Okay. Then arthritis. Arthritis, you always know rheumatoid arthritis is a joint involvement which involves small joints and multiple joints, like more than 10 small joints involvement is given a score of 5. Okay. And arthritis. Itis means it is a chronic inflammation. So chronic inflammation means what parameters you can check? You can ask in history, like symptom duration, more than 6 weeks, chronic. Okay. Or acute phase reactants like ESR, CRP, chronic. So 4 parameters I have told only with the name of rheumatoid arthritis itself. Rheumatoid factor, arthritis, joint involvement, small joint involvement, large joint involvement, itis, chronic inflammation. So it can be ESR, CRP or symptom duration of more than 6 weeks. So total, if it is more than 6, it's definitive rheumatoid arthritis. Okay. Yes. So this is the microscopic picture, like histopathological finding, where you can see a granulation tissue forming over the joint and eroding the joint. Erosive arthropathy it is. Okay. So having macrophages, plasma cells, dendritic cells, and immune complexes. Nothing but pannus with erosive joint damage. Okay. Next, patient with migraine develops chest pain and tightness after taking sumatriptan. There is a family history of coronary artery disease. Which of the following is most appropriate for migraine prophylaxis, they have asked. Okay, so this also we have discussed. Migraine prophylaxis, nothing but acute attack. Treatment is first line is NSAIDs or antiemetics. And next comes your triptans. Okay, your triptans mechanism of action we have discussed 5-HT 1B 1D agonism. But what is the side effect of triptans? This 1B agonism causes vasospasm. We don't want vasospasm in patients of MI as well as peripheral arterial disease. Risk of gangrene, risk of MI is there with respect to triptans like sumatriptans. So what is the latest drug we discussed? It is only 1D agonism. It doesn't have 1B agonism. No vasospasm. What is the drug? Which is lasmiditan, which is the drug of choice in MI patients, PAD patients having migraine. Drug of choice. But they in exam they have asked prophylaxis of choice in post-MI patient. So best should always be a beta blocker. Beta blocker we always prefer in post-MI patients to prevent antiarrhythmic effects. Okay, and it also has a migraine prophylaxis effect also. So best option should be propranolol and not topiramate. Okay, so answer should be propranolol. Next is patient presenting with dyspnea stridor. HPE shows hilar lymph nodes with non-cascading granulomas with giant cells, and in some recall I have seen like stellate granulomas were also given. So most likely diagnosis, no doubt, if it is stellate granuloma, non-cascading granuloma is there, then option should be sarcoidosis. Okay, yes. 30-year-old asthmatic woman on salbutamol and ipratropium reports frequent nocturnal wheeze. Best next step. So this also we discussed is nothing but GINA guidelines. Only they have asked. See, GINA guidelines, they have classified asthma patients into 5 steps. Like first step is symptoms within a step 1 and 2 is having symptoms in a week. Okay, less than 4 to 5 days in a week. Step 3 and 4, almost daily symptoms with deranged PFTs. The deranged PFTs will be there in step 4. Okay. And step 5, if the patient is refractory to therapy, then it is step 5. So how to treat all these steps? First is just to give SOS basis, give ICS, formoterol. Okay. And step 3, if it is going to step 3, you're always going to give a low dose inhalational corticosteroid with a formoterol daily. Daily maintenance therapy should be given. Step 4, medium dose ICS formoterol daily should be given. Step 5, high dose ICS formoterol with biologicals or LAMA can be added. So here if you see, you should obviously in the patient is not at all taking steroid itself. ICS itself is not taking. So you should obviously add a LABA with the ICS. So last, the patient collapses with breathlessness and pink frothy sputum. Autopsy shows hemosiderin-laden macrophages. In which condition is this is not seen? This is the controversial question, but I'll tell the answer for this. See, we have discussed that where does pink frothy sputum appears? In any conditions where there is raised LVDP, like any valvular heart disease, any cardiomyopathy, where there is increased LV end diastolic pressures, left atrial pressure will increase and pulmonary venous pressures will increase, resulting in increased hydrostatic pressures and increased microvascular permeability and pulmonary edema. Patient will be having the pink frothy sputum because alveolar edema fluid combined with this air bubbles will form a froth. Okay, pink frothy sputum will be seen. So obviously you will be seeing in volume overload and pulmonary vein obstruction, because pulmonary vein, if it is obstructed also, this is the pulmonary vein. If pulmonary vein is getting blocked here also, there will be back pressure increase and there will be pulmonary edema. So obviously these two are right answers. Next comes to protein losing enteropathy. See here, this is nothing but hypoalbuminemia. Hypoalbuminemia itself is a risk factor for pulmonary edema because low oncotic pressure will lead to exudation of fluid in the capillaries like alveoli and it can cause pulmonary edema. So only option is right heart failure, which never causes pulmonary edema, because right heart failure, if you see, right heart is failing means there should be features leading to increased JVP, neck vein distension. Okay, and also if you see, there can be tender hepatomegaly due to enlargement of liver, nausea, vomiting, jaundice can be seen, and due to enlargement of vena cava, there can be pedal edema, ascites, pitting pedal edema can be seen, splenomegaly can be seen, and due to fluid in the gastrointestinal tract, patient will be having malabsorption and weight loss, which is called cardiac cachexia. So all these are possible in right heart failure, but never pulmonary edema. So answer is right heart failure. Next is last is child with a CKD has calcium of 7, phosphate of 6.7, high PTH and elevated ALP. What is the next step in management? See, here they have given high PTH and elevated ALP. Calcium is low, normal is 9 to 11, calcium is very low and phosphate is high. So how are you going to manage this patient? So see, elevated ALP means increased bone turnover. Okay, there is increased bone turnover happening. Why it is happening? Due to high PTH. Let's see what is happening. Increased hyperphosphatemia. What happens? Stimuli for PTH release. Because in this thing, if you see, in CKD patients, there is a chronic hypocalcemia, which is a stimulus for continuous secretion of PTH. And if PTH is continuously secreted, it is a phosphate thrashing hormone. Okay, it tries to wash off the phosphate out of the body. But in CKD, since the nephrons are fibrous, it can't wash off phosphates. Okay, so what will happen is it can only increase the calcium levels and it cannot decrease the phosphate levels. So, and what happens is in CKD patients, due to increased phosphate and decreased calcium, so what is happening actually here is this elevated PTH can't act on the kidney and activate vitamin D. Okay, this doesn't happen because the nephrons are fibrous. PTH, increased PTH acts on the bone. It stimulates the osteoclast, which just eats the bone cells, and this bone cells are replaced by fibrovascular tissue. Okay, nothing but what we'll call it as osteitis, inflammation of bone. Osteitis, fibrosa, and the bones are converted into cyst. Fibrosa cystica. Okay, where the elevated PTH is just targeting the bones, because why it is targeting the bones? Because the body needs calcium from somewhere. So it is just targeting the bones and it is trying to replace the bone by fibrovascular tissue and getting calcium from the bones. So only we are getting all these findings. Like skull, we will be having this findings. Okay, this the skull. Okay, and also you can see cystic lesions in the phalanges also. This is also classical of CKD. Okay, and also you can see this complete destruction of the bone marrow resulting in pancytopenia. All these are possible. Okay, all these are possible with respect to hyperparathyroidism. So here, if you see, this is the cystic finding seen in the phalanx of the CKD patient. So here, how to treat this patient? What is the problem causing this? Increased phosphate and decreased calcium. So how to treat this? Give phosphate binders like sevelamer, levolamir, lanthanums, you can try. And hypocalcemia can be corrected by calcium supplements. And here it's a crux question is, patient is vitamin D levels you should see. Only if it is low, you can give vitamin D. If vitamin D is normal, you should not appropriately supplement the patient with vitamin D. Because if you give vitamin D, both calcium and phosphate will increase and this phenomenon will replicate again. So answer should be a phosphate binder with calcium supplement should be the best answer for this. Okay. Yes. So that's it with the recall. We will. Thanks for your time. Hope you understood a lot of things. Thank you.